Hello, my name is Srutti Suresan. I'm a final year medical student, and I'm going to go through some topics on gastroenterology. These are the topics I'm going to cover in this session. Diarrhea is a common presenting complaint, so firstly, let's clarify this term. Diarrhea is defined as the passage of 3 or more loose or liquid stools in a day, or when the stools are more frequent than what it is normal for the patient, lasting less than 14 days, or when the stool weight is greater than 200 grams a day. Based on duration, so how long the diarrhea has been going on for, it can be categorized into acute, persistent, or chronic diarrhea. The table on the right shows a diagram of the Bristol stool chart, which is a diagnostic scale that assigns a number 1 to 7 to stool samples based on its shape, color, and consistency. This is important because it allows us to gauge what is normal for the patient and to identify what the patient is currently experiencing. Therefore, this is quite handy when taking a history. There are many causes of diarrhea, and the causes are different depending on whether the patient is experiencing acute or chronic diarrhea. Possible differential diagnoses of acute diarrhea are constipation causing overflow, infective causes such as gastroenteritis, C. diff, or Whipple's disease, diverticulitis, which is the inflammation of the outpouchings of the large bowel, acute exacerbations or first presentation of UC or Crohn's disease can present as acute diarrhea, and medications can cause side effects like diarrhea as well. Under causes of chronic diarrhea, we have irritable bowel syndrome, inflammatory bowel disease, which consists of Crohn's disease and ulcerative colitis, colorectal malignancy, malabsorption disorders such as celiac disease, lactose intolerance, and pancreatic insufficiency, and we also have hyperthyroidism. Another term that is important to know is steatorrhoea, which means that the stool has excess fat. This is often due to a problem in either fat digestion or fat absorption. It often presents as pale, bulky stools, which is offensive in smell, and the patients often complain that the stools are difficult to flush away. Now let's talk about some of the differential diagnoses of steatorrhoea. Steatorrhoea is seen in chronic pancreatitis and cystic fibrosis due to fat digestion problem. This is because in these conditions, the pancreatic enzymes are deficient in the body, causing in order to break down the fat, and therefore there is a problem in the pancreatic exocrine function. Steatorrhoea is also seen in celiac disease, Crohn's disease, and Giardia infection, and this is because fat malabsorption occurs as these diseases affect the small intestines. And also patients with bile salt deficiencies can also experience steatorrhoea. So examples of these are primary biliary cholangitis, primary sclerosing cholangitis. And other causes of steatorrhea are post-gastrectomy and Graves' disease. So now, how would you investigate someone presenting with diarrhea or steatorrhea? Well, firstly, you need to obtain a thorough history, and the history would include the following questions. So you'd ask about the onset, frequency, and duration of diarrhea, inquire about the presence of blood, mucus, or pus in the stool, whether they have difficulty in flushing the stool away, any associated abdominal pain, bloating, flatulence, constipation is important. You'd ask about any systemic symptoms such as fatigue, night sweats, fever, and weight loss. And you'd ask about whether they have been in hospital recently, ask about their surgical history, travel history, drug history, and also family history, particularly about GI disorders and even systemic disorders like diabetes. After this, you'd also perform a physical examination, which would include checking the hydration status, an abdominal examination, and you may need to do a digital rectal examination if required. In addition to this, you would take a stool sample to be assessed for various things. You can send it off to microbiology to look for pathogens such as ova and parasite testing, bacterial testing, and even toxins. And you can also look for fecal leukocytes, which would be raised in infection. You can do a fecal occult blood test to check for malignancy, and a fecal calprotectin to check for inflammatory bowel disease. And if you suspect pancreatic insufficiency, then you can do a fecal pancreatic elastase test. You would also do blood tests. So you'd request for full blood count. This may show iron deficiency anemia, and this indicates that they are bleeding. CRP and ESR would be raised in inflammatory bowel disease. You may want to have a look at their baseline renal and liver function, and especially when hypothyroidism is suspected, you'd have to do thyroid function tests. And to rule out celiac disease, you can do antibody tests, which I will talk about later. And you may, if consider ovarian cancer in patients presenting with diarrhea with other relevant symptoms. So in that case, you would consider to check the tumour marker levels for ovarian cancer, which is CA125. Furthermore, you would also want to do some imaging. So you could do an abdominal x-ray, and if you want to visualize the GI tract, you can order a flexible sigmoidoscopy or a colonoscopy, and this would also allow you to take a biopsy. And you could also do take a barium enema. You could also refer them to do a barium enema if needs be. So now let's look at the infective causes of diarrhea a bit more closely. Gastroenteritis is a non-specific term which refers to the acute inflammation of the lining of the stomach and intestines due to an infective cause. There are many pathogens that can cause diarrhea or vomiting, and I've highlighted a few important ones on the table. Viral causes are norovirus, rotavirus, and adenovirus. Bacterial causes can be Campylobacter, E. coli, Salmonella, and Shigella. And Staph aureus and Bacillus cereus, they are both bacteria. However, it's not the bacteria that causes gastroenteritis, but it's actually the toxins that the bacteria release that causes the symptoms. And that's why I put them on a separate column. And some causes of parasitic causes of gastroenteritis are Cryptosporidium, amoeba, and giardia. It is important to note the differences in the presentation of gastroenteritis, because it helps to determine the causative pathogen, and this enables us to provide an appropriate management plan for the patient. So let's take a look at the presentation a bit more closely. Norovirus is often the cause of the winter vomiting bug. The incubation period of norovirus and rotavirus is very similar, and also the presentation is quite similar. However, the difference is that rotavirus is more commonly affects children less than 5 years of age, and that's really important to note. Now, Bacillus cereus and Staph aureus similarly have a cause. Both Bacillus cereus and Staph aureus can cause acute food poisoning. The incubation period are somewhat similar. It's around 1 to 6 hours. And the difference is that, firstly, Bacillus cereus is a gram-positive rod, whereas Staph aureus is a gram-positive cocci. And Bacillus cereus is a result of undercooked or reheated rice, whereas Staph aureus is a result of ingestion of contaminated beef, pork, poultry, or eggs. These differences are really important to recognize. Now, moving on to Salmonella and E. coli, they are both gram-negative rod with a similar incubation period. And Salmonella can cause bloody diarrhea and is often the result of contact with contaminated animal products such as unpasteurized eggs or milk. And with E. coli, it commonly presents with watery diarrhea, and this is also known as traveler's diarrhea. However, there are many different strains of E. coli. So when you have gastroenteritis caused by the strain BTEC0157, it often causes bloody diarrhea with severe abdominal cramps and nausea. Regarding management of all these type of gastroenteritis, it is often supportive management, where you would check the patient's hydration status and hydrate them as required. And a bit more on gastroenteritis. So cholera is a gram-negative rod, and its incubation period is between 12 hours and 5 days. It presents as a profuse rice watery diarrhea with dehydration and hypoglycemia, and it's often due to contaminated water or food. The management for cholera is oral rehydration solution with broad spectrum antibiotics. So this means doxycycline or ciprofloxacin is used. Shigella and Campylobacter are similar because they are both gram-negative rods and they both have a similar incubation period, and they both can cause bloody diarrhea. However, the difference is that Campylobacter presents with a flu-like prodrome, and the complications associated with Campylobacter includes Guillain-Barré syndrome and reactive arthritis, which is not seen with Shigella. Amoeba and Giardia are parasites that have an incubation period of greater than 7 days. However, the difference is that amoeba causes bloody diarrhea, whereas Giardia causes non-bloody diarrhea. They are both treated with metronidazole. However, with amoeba infection, you give them metronidazole for 4 to 5 days, and then you also give them a 10-day course of diloxanide. Cryptosporidiosis is also a parasitic cause of gastroenteritis. This is more commonly seen in immunocompromised patients, such as HIV patients, particularly when they have a CD4 count of between 100 and 200 cells. and this presents as non-bloody diarrhea. And when investigating for this particular cause of gastroenteritis, you can use a Ziehl-Neelsen stain, and it will reveal a red cyst in the stool. And this is very characteristic of cryptosporidiosis causing gastroenteritis. Now let's talk about C. diff infection. C. diff is a gram-positive rod bacteria, and it is often and the infection often occurs due to clindamycin use, second or third generation cephalosporin use, PPI, and often seen in patients who have been recently hospitalized or in hospital. This infection can result in the formation of pseudomembranes and cause inflammation of the colon, so it's also known as pseudomembranous colitis. In order to diagnose C. diff, we need to detect either the bacteria or its toxins in the stool samples. And normally you detect toxins in the stool sample by using the cytotoxin test or the enzyme-linked immunoassay technique, and you can also directly culture C. diff from the stool. Management is with 10 to 14 days of oral metronidazole, and if this doesn't help to solve the problem, then you can give them oral vancomycin. In severe infection, you would give them a combined treatment of oral vancomycin and intravenous metronidazole. Now, let's look into malabsorption. This refers to the failure to fully absorb nutrients from the gastrointestinal tract. Malabsorption could present with chronic diarrhea, steatorrhoea, changes in weight and growth, and often has signs of deficiencies such as iron deficiency, folate, or B12 deficiency. There are many differential diagnoses of malabsorptions as highlighted on the table. In this session, I would only be concentrating on celiac disease. However, the other causes of malabsorption is important to recognize. So, celiac disease. Celiac disease is an autoimmune condition due to hypersensitivity to gluten. It is associated with dermatitis herpetiformis, type 1 diabetes, autoimmune hepatitis, autoimmune thyroid disease, and also associated with the HLA-DQ2-DQ8 subtype. It is important to know that repeated exposure to gluten leads to villus atrophy, and it is this that results in malabsorption. So, features of celiac disease are diarrhea, steatorrhea, bloating, abdominal pain, anemia. Both they could present with iron and or folate/vitamin B12 deficiency. They can experience fatigue, weight loss, failure to thrive, and even osteopenia/osteoporosis. You will do a range of investigations, and the first line investigation in celiac disease is to do IgA/TTG antibodies. Second line is to do endomysial IgA antibodies. It's important to note that both of these two antibodies are IgA antibodies. So in patients who are IgA deficient, you would do antiglidin IgG antibody test. The gold standard test for celiac disease is to do a duodenal biopsy. This would show villus atrophy, crypt hyperplasia, increase in intraepithelial lymphocytes, and increased lymphocytic infiltration in the lamina propria. The patient must eat gluten for at least 6 weeks before they are tested. Otherwise, you won't be able to see the changes. And you may also want to consider to do a bone scan in patients with suspected celiac disease. Management is to have a gluten-free diet. This means there should be no wheat, barley, or rye in their diet. They would also have to take calcium and vitamin D tablets. And if they're deficient in iron, then iron tablets needs to be taken. And one of the complications of sort of celiac disease is that they can have functional hyposplenism, and therefore in these patients it's important that they take the pneumococcal vaccination every 5 years. Now let's talk about irritable bowel syndrome. Irritable bowel syndrome is a chronic condition characterized by abdominal pain associated with bowel dysfunction. You need to consider a positive diagnosis of IBS in patients presenting with abdominal pain that is relieved by defecation or associated with altered bowel frequency or stool form. And in addition to this, they should have at least 2 of the following: altered passage of stool, such as straining, urgency, or incomplete evacuation, abdominal bloating, distension, or hardness, and the symptoms should be aggravated by eating, and there should be passage of mucus rectally. It is important to note that IBS is not a diagnosis of exclusion of organic disease, but it should be made, the diagnosis of IBS should be made positively on a symptom-based criteria, which I just spoke about on the slide previously. In addition to the symptoms, you would also have to do other investigations, which comprises of stool sample studies, looking for leukocytes, and doing fecal calprotectin test to rule out IBD. You would also do FBC, ECR, CRP, and even antibody tests for celiac disease, and CA125 markers, and you check for CA125 markers in women with suspected ovarian cancer. The treatment of inflammatory bowel syndrome can be split into conservative treatment and medical treatment. So conservatively, a lot of emphasis is placed on diet. It's important for the patient to have regular meals and to drink at least 8 cups of fluid per day. They should restrict caffeinated drinks, restrict alcohol and fizzy drinks as well. Regarding food, they should limit the intake of high fiber food and resistant starch, and limit fresh fruit to 3 portions a day. It's important that people with diarrhea should avoid sorbitol, and for those who experience wind and bloating, they may find it helpful to eat oats and linseeds. And also, FODMAP diet is recommended in patients experiencing IBS. IBS is also related to stress, and so interventions need to take place to reduce the amount of stress that they may experience. Regarding medical treatment, if patients can present with constipation or diarrhea in IBS. So for those who experience more constipated symptoms, they should be prescribed laxatives. And it's important to remember that they should not be given any lactulose as a form of laxative. If in those patients where laxatives has not relieved the constipation and it's been going on for 12 months, then they can be offered a medical drug called linaclotide. Sorry, I don't know how to pronounce the name, but you would offer that if the problem is not resolved by laxatives. In patients with diarrhea symptoms, you'd give them loperamide. And in patients where medical, both laxative or loperamide have not worked, then you may want to consider TCA, tricyclic antidepressants. And if TCAs are inefficient, then you can offer them SSRI to help combat IBS symptoms. If they do not respond to any medical therapy, then you may consider referring them for psychological intervention. Now let's talk about inflammatory bowel disease. Firstly, ulcerative colitis. UC is a non-granulomatous inflammatory bowel disease. It only affects the large bowel. It affects only the mucosal part of the bowel, and you'll see crypt abscess formation, and there'll be goblet cell hypoplasia. Due to the repeated cycles of ulceration and healing, there may be raised areas of inflamed tissue, and this is known as pseudopolyps. And often the rectum is the most affected site in UC. The features of UC can be split into intestinal features and extra-intestinal features. Intestinal features comprise of bloody diarrhea, PR bleeding, mucus discharge, increased frequency, urgency of defecation, and tenesmus, and also left lower quadrant pain. Extraintestinal features include erythema nodosum, pyoderma gangrenosum, arthritis, anterior uveitis, episcleritis, and primary sclerosing cholangitis. It's really important to remember that smoking is actually a protective factor in UC. As part of the workup for UC, you must obtain a stool sample to check for fecal calprotectin. You would want to do an abdominal X-ray, especially in an acute exacerbation scenario, in order to exclude toxic megacolon, which is a possible presenting complaint. And you would also want to do an abdominal X-ray because it can show features of UC, such as thumbprinting. And this is highlighted in the X-ray below with the arrowheads. This is when there is thickening of the haustral folds, so there's bowel wall thickening, and this indicates acute inflammation. It's important to do a colonoscopy because that's the gold standard investigation to confirm the diagnosis of UC, and you'd also do a biopsy along with it. In some cases, you may want to do a small bowel enema, and this can show lead piping, which is when there is the loss of haustral markings in the diseased segment of the colon, and you may also be able to visualize pseudopolyps. The diagram on the left illustrates the different types of UCs you can get. Proctitis refers to inflammation of the rectum alone. You can also get proctosigmoiditis, which is the inflammation of the rectum and the sigmoid colon. Distal colitis affects the rectum, sigmoid colon, and the descending colon. Extensive colitis is when the transverse colon is also affected, and pancolitis is when the entire large bowel is affected. The diagram on the right is very important to know because the treatment plan is dependent upon recognizing the severity of the disease. So, if the patient complains of less than 4 bowel movements per day, it is considered as mild. and 4 to 6 is moderate, and greater than 6 is considered to be severe UC. In addition to that, in severe UC, there will be presence of blood in stool. The patient will have pyrexia, have tachycardia of greater than 90 beats per minute, and anemia, and an ESR of greater than 30. There are two components in managing UC. Firstly, it's important to induce remission, and then secondly, you need to maintain remission. The induction and maintenance therapy is dependent upon the extent and severity of the disease. So now, regarding inducing remission, in mild to moderate UC or proctitis, the first line therapy is topical aminosalicylate, and similarly in proctosigmoiditis or left-sided ulcerative colitis, the first line is also topical aminosalicylate. I hope I'm saying this correctly. I'm sorry for my pronunciation. And also in extensive disease, you also have a topical aminosalicylate, but also you give them an oral high dose aminosalicylate. In severe disease, you give them IV hydrocortisone, and you also assess the need for surgery. With regards to maintaining remission, you give topical aminosalicylate alone or in combination with oral aminosalicylate in proctitis or proctosigmoiditis. In left-sided and extensive ulcerative colitis, you give them low maintenance dose of an oral aminosalicylate. However, in a patient who has had 2 or more inflammatory exacerbations in 12 months that require treatment with systemic corticosteroids, or if remission is not maintained by aminosalicylate, or if they've had a single acute severe episode of UC, then you would offer them oral azathioprine or oral mercaptopurin in these patients. Now, moving on to Crohn's disease. Crohn's disease is a non-caseating granulomatous inflammatory bowel disease. A caseating granuloma would be intestinal tuberculosis. Unlike UC, Crohn's disease affects any part of the GI tract from mouth to the perianal area. It commonly affects the distal ileum and the perianal area. The inflammation is transmural, therefore this means that it affects all layers of the intestinal wall, leading to stricture formation, fistulas, perforation, and abscess formation. There is discontinuous inflammation, so skip lesions are present, which means that diseased lesions are separated by healthy areas. Whereas in UC, the inflammation is continuous. So the intestinal features of Crohn's disease include perianal disease, right lower quadrant and periumbilical pain, diarrhea, bowel obstruction, fatigue, and even abdominal mass. Extraintestinal features include erythema nodosum and pyoderma gangrenosum, arthritis, episcleritis or anterior uveitis, which is similar to UC. You also get renal stones, gallstones, and primary sclerosing cholangitis. However, primary sclerosing cholangitis is much more common in UC, and therefore it also increases the chances of cholangiocarcinoma. Similarly to UC, investigations include stool sample, abdominal X-ray, and you may also want to do an MRI for perianal disease. It would also include colonoscopy with a biopsy, and here you can see cobblestoning, which is characteristic of Crohn's disease. And when you do small bowel enema, you would see strictures and rose thorn ulcers, fistulae, and proximal bowel dilation, which is very characteristic of Crohn's disease. Similarly to UC, management compromises of inducing remission and maintaining remission. So, in order to induce remission, in patients presenting with the first presentation or a single inflammatory exacerbation of Crohn's disease in a 12-month period, they are given glucocorticoids such as prednisolone as first line. In patients with one or more of distal ileal, ileocecal, or right-sided colonic disease who decline glucocorticoid or is contraindicated to be given glucocorticoid, then you can offer them budesonide, and if not, then an aminosalicylate. I'm sorry, it's a bit of a mouthful. I hope the slides are clear in explaining this. And if there are two or more inflammatory exacerbations in a 12-month period, then you can add azathioprine or mercaptopurin to a corticosteroid or budesonide. And second line, you give them methotrexate. Regarding maintaining remission, it is important for them to stop smoking. So in UC, smoking is a protective factor, whereas in Crohn's disease, it exacerbates the symptoms. So you want them to stop smoking. And to maintain remission, first line treatment is azathioprine and mercaptopurin, and second line is methotrexate. In fistulating Crohn's disease, you can give them metronidazole or ciprofloxacin. You would consider surgery in patients with early disease limited to the distal ileum, or in patients with severe disease, or in patients with chronic active disease. Now, to the final part of the presentation, we're going to look into nutrition. You need to be aware of how vitamin deficiencies may present. So, vitamin A is called retinol. When vitamin A is deficient, it can cause night blindness. The cause of vitamin A deficiency is usually inadequate intake, liver disorders, or fat malabsorption. Vitamin B1 is called thiamine. You often get thiamine deficiency due to alcohol abuse or malnutrition. And there are 4 types of presentation in which a patient can present with thiamine deficiency. So, firstly, we have Wernicke's encephalopathy, which is a triad of nystagmus, ophthalmoplegia, and ataxia. Then you can have Korsakoff syndrome, which is when a patient presents with amnesia and confabulation. Confabulation means making up stuff. And they can also present with peripheral neuropathy and dilated cardiomyopathy. Vitamin B3 is called niacin, and in niacin deficiency is called pellagra when it's severe, and this presents as a triad, and it's easy to remember because it's the 3 Ds: dermatitis, diarrhea, and dementia. This is often the result of inadequate intake of vitamin B3, alcoholism, and also due to prolonged treatment with isoniazid therapy. Vitamin B6 is called pyridoxine. This causes peripheral neuropathy or sideroblastic anemia. the number one cause of vitamin B6 deficiency is isoniazid therapy to treat tuberculosis. And so when isoniazid therapy is initiated, they are also given supplementations of pyridoxine to prevent pyridoxine deficiency from occurring. Now, vitamin B12 is something that you should be familiar with. It causes macrocytic anemia, sore tongue, presents with sore tongue and sore mouth, and it presents with subacute combined degeneration of the spinal cord. So you lose your joint position and vibration senses first. And you can also have a mixture of upper motor neuron symptoms and lower motor neuron symptoms. So you can have absent ankle reflex and increased knee reflex. So the causes of vitamin B12 deficiency is pernicious anemia, post-gastrectomy, vegan diet, and disorders of the terminal ileum such as Crohn's disease. Then we have vitamin C deficiency. So this presents with follicular hyperkeratosis and perifollicular hemorrhage. There could be easy bruising or poor wound healing. It's often associated with receding gums and gingivitis with bleeding gums. And there is an association with arthralgia, which is joint pain, and Sjögren's syndrome. Vitamin C deficiency is often a result of malnutrition, alcohol abuse, and limited access to fruits and vegetables. Finally, I'm going to talk about enteral nutrition and parenteral nutrition. So, enteral nutrition means when nutrition is delivered directly into the stomach, duodenum, or the jejunum. There are different types of enteral feeding, and this includes nasogastric or nasojejunal tube. This is often given in patients in short term, so less than 4 weeks, and it's important to check that the nasogastric tube is placed correctly, because if it's misplaced, that means it's gone into the bronchus, and it can cause aspiration problems. So before you administer any feed, you need to check whether the NG tube is correctly positioned, and you can do this by taking a gastric aspirate, and if it's positioned correctly in the stomach, then the pH should be acidic, so less than 5.5. If this is difficult to do, or you don't get the desired outcome, then you can double check by doing a chest x-ray. Another form of enteral feeding is the PEG tube, so gastrostomy feeding tube, and this is given to patients for long-term feeding requirements. And another example of enteral feeding is percutaneous jejunostomy tubes. And that's only given if the stomach is inaccessible or if there's any outflow obstruction. Now, parenteral feeding refers to the IV administration of nutrients, and it is often only used in patients who are malnourished or at risk of malnutrition and have a non-functioning or inaccessible GI tract, preventing enteral feeds. I hope that makes sense. So you only give parenteral feed if they cannot have enteral feeds. So you can give parenteral feeds via a PICC line if you're only wanting to feed them for less than 2 weeks, or you can give it via a central catheter, and this is often used for long-term feeding. This is a diagram that sort of helps to illustrate the different type of feeding. So as you can see, PPN and TPN refers to parenteral nutrition, and this goes directly into the vein, whereas the others, i.e. nasogastric tube, nasoduodenal tube, and nasojejunal tube, goes directly into the mouth, into the nose, even, and goes down to the stomach, or the duodenum or the jejunum. And then you also have the gastrostomy tube or the jejunostomy tube that feeds directly into the stomach or the jejunum from the outside. I hope my explanations were helpful. So good luck with all your exams. If you can fill out the feedback form when you get access to the PowerPoint slides, that will be great. And yeah, once again, good luck, and I hope you found this useful. Thank you.